We have with us today Dr. Hsiang, and he's with us today to talk about his role as a person who has been a whistleblower in British Columbia, who has criticized and exposed as a medical doctor things that he's concerned about with respect to the COVID measures in British Columbia. Dr. Hsiang.
Hi, Gail. Hi, Matthew. Thanks very much for coming today and interviewing me. I like to begin by saying that my story is a little bit unique and kind of similar to other people's. And so there will be similarities and differences. So let me tell you a little bit about myself. I have been an outsider for all of my life. The reason I say that is because I was born in Taiwan to a Taiwanese diplomat. And so my life for the first 18 years was constantly traveling to other countries with my family, being uprooted from various schools, and coming back to Taiwan when I was actually quite young, at 12 years old. And at that point, having received my education only in English, I was unable to speak, write, or communicate in any way in Chinese. And so I experienced reverse discrimination on a very personal level. And I would say that my 3 years in Taiwan at the time taught me so much about my subsequent self, in that I figured out what I needed to do to survive. It wasn't pretty, but that's what I did. And then from there, I would say that, again, being an outsider, I went to medical school in New Zealand, and it was by serendipity that I got into medical school, not because of my academic performance, but because of my status. At the time, I was, if you like, a New Zealand resident, but not quite a New Zealand citizen yet. And so my time in medical school, after I got in, it was actually a wonderful time. But I would say that there's certain key events that happened in medical school that really made me think about what is it that we really need to know. And one of the key things that made an impression upon me was that the head of pediatrics got up in front of the entire class and said, how many of you know one medication that we use to treat acute leukemia in children? And everybody put up their hands, because at the time there was maybe about 4 to 6 different drugs one could use. And then he said, how many of you know what the caloric content of breast milk is? And not one person could put up their hands. And then he said, you guys have no idea of what is important. The risk of acute leukemia in children is 1 in 10,000, but every child drinks breast milk. And then it was really a criticism of medical school education and the focus on drugs. Another comment that one of my teachers, this was in cardiology, he said, any drug can do anything. And then he's left it at that. And it made me ponder for many, many years afterwards what exactly he meant, until I came across a whole bunch of side effects that different drugs could cause. And then I realized exactly what he was talking about. I came to Canada at the end of my medical school, and I, if you like, transitioned from a truly Commonwealth education in New Zealand to what I believed was going to be a Commonwealth education in Canada, but soon realized that Canada, in fact, is only a Commonwealth country in name. And its medical curriculum is entirely American focused. It is not focused on the British Commonwealth countries. And so when I came to Canada as a resident at the time, I was very good at the practical things, because that's what they emphasize in New Zealand. And so I was very good at drawing blood from people, putting in IVs, and doing things like putting in nasogastric tubes, urinary catheters, ECG. And so we learned very quickly that if you order these things, you have to do them yourself in New Zealand. And so when I came to Canada, I realized that the Canadian medical students and residents were all very smart and very knowledgeable, but none of them could do any of these practical things. And so it was with that understanding that I began and realized that there are key differences in the medical education between the two countries. One of the key differences is that there is gross inefficiency in the Canadian healthcare system. This was back in the early 80s, whereby we would, for instance, go to the ward, commence rounds in New Zealand at 8:15 and go to the operating room at 8:30. And we would operate from 8:30 to 3:30. Here, you were meant to start your rounds at 7 in the morning and be in the operating room at 7:45. For an operation, it doesn't start until 8:30. And then you would be in the operating room till 4:30. After that, what happened in New Zealand was that the consultants would operate during the day, and at night, the residents were all on their own. And the consultants would rarely ever come in. In Canada, the consultants come in for every case, and that is probably unheard of anywhere else. The Canadian public does not know how good they have it when the consultant surgeon comes in to do every case or oversee every case at night, irrespective of how trivial it is. Whereas in the rest of the Commonwealth, and I would say probably the rest of the world, the majority of the cases done at night is purely done by residents, largely unsupervised. And so that was one of the striking differences that I experienced. During my surgical residency, as I said, I've always been an outsider. I actually quit after my first year of surgical residency because I hated it so much. But by some stroke of luck, and that's a fairly long story I won't get into, I went back and completed my surgery. The primary reason was that I was in conflict with my choice of surgery, because as a medical student, I never thought I'd become a surgeon. My interest was in the exact opposite of surgery, which is internal medicine. But nonetheless, I continued my education in surgery, and then we had a course partway through the surgical residency called clinical epidemiology, and that really woke me up in terms of they would start off with a premise saying that you have an abnormal blood test result. What's the likelihood that you actually have the problem? And everyone, at least at that time, thought that it was definitive. And they said, no, if you have an abnormal blood test result in a person who has actually no other features, the most likely thing is that the blood test is wrong. The number one thing you should do is redo it. And so that led me down the path of questioning dogma in my area of surgery as well as medicine in general. And then what can one do to correct these questions? And so I was very interested in that entire field of clinical epidemiology. And in my final year of general surgery residency, I was a general surgeon first and then went on to become a vascular surgeon. But in my final year of general surgery residency, where I was known as the chief resident, we're responsible for giving a round every week. And I recall vividly, I came across an article that was written by a Dr. Barry Marshall, an Australian, who basically said something that went completely against the grain of what was known at that time for stomach ulcers. We had this paradigm was no acid, no ulcer. And so as a result of it, we were always trying to kill the stomach acid in order to prevent ulcers. And we would do it in a number of different ways. We would do it either by giving medications, you've heard of antacids, certain antacids called cimetidine, otherwise known as Tagamet, and we would do it surgically by denervating or cutting the nerves to the stomach in order to stop acid production. Dr. Barry Marshall's article was fascinating in that he basically said that the cause of stomach ulcers is not acid, it's bacteria. And he identified the bacteria in it. And he believed in that so much that he himself fulfilled what's known as Koch's postulates. by identifying that bacteria, isolating it, and then he himself drank the isolate to produce ulcers. Now, once he produced the ulcers, he knew it's a bacteria, it could be treated with antibiotics. He actually took the antibiotics and cured himself. When I presented that paper to the entire group of general surgeons whose entire careers were based on no acid, no ulcer, they poo-pooed it immediately. That was a striking thing, and yet I thought scientifically that was so valid. How could you really go against this? And so, to his credit, Dr. Barry Marshall continued on with his course and was subsequently awarded the Nobel Prize in Medicine for his discovery. And all I can think of is that all of those researchers, all of those surgeons, all of those otherwise medical doctors who had been trying to treat stomach acid problems by giving antacids or surgeons cutting the nerves to the stomach, they were completely wrong, and they have been wrong for about 60, 70 years at that point. And so as I started my career in vascular surgery, which is a specialty of general surgery, we only operate on blood vessels. So we operate on all the blood vessels in your body, with the exception of not in the brain and not in the heart. And so with that knowledge, it's actually kind of scary when you're let out on the public, now that you have to operate on your own. And I would say we received very good training for it, but sometimes your training is just not adequate for a number of the things that would come along. And as I acquired experience with it, I, like most surgeons, discovered what I liked doing, came across certain techniques that worked for me and other techniques that did not. At this point, I had completed my residency in general surgery, a fellowship in vascular surgery. I went on to do a master's in clinical epidemiology, and I went on to do research in vascular surgery. And when I came back to the University of British Columbia, I was very different from all the surgeons, because I was focused on becoming a true academic surgeon since I had been trained so well. And by that, what I mean is that my interest extends beyond treating the individual patient. My interest lies in treating the population of patients who may have a certain illness. And so by that, what I mean is that an academic surgeon, a truly academic surgeon, is like any other academic in that majority of the time is spent writing. And so I would be writing grants and papers, and I was completely different from all the other surgeons in my group. I enjoyed surgery because I enjoyed the immediate fulfillment of making a patient's life better. But prior to that, there is the entire process of seeing the patient, evaluating the patient, recommending surgery, getting consent for the patient. And I would say along the way, there was a very inflammatory comment made by the person who held the title of Vice President of Medicine at the Vancouver General Hospital. And so his name was Charles Wright. And Charles Wright is not a friend of any physician at the Vancouver General Hospital, because of dogmatic statements like, the most dangerous physician is a young surgeon with a mortgage and an empty operating room. And by that, what he meant was that surgeons or physicians are small business people. They need to do their business in order to get paid. In your case, or in the case of, let's say, a young surgeon who does not have many patients at the time, their indications to treat surgically would become much more lax, if you like. And so that produced a controversy of storm at the time. But in reality, there is some truth in it, in that, sure, I mean, if all you have is a hammer, everything looks like a nail at that point. And so, as I continued through my career, I was in eternal conflict, I would say, probably for the first half of my career as a surgeon in a teaching hospital. And the conflict is my responsibility to my patient directly in front of me to do my best, or it's my responsibility to the next group of young doctors. Those are the students and residents. They're all inferior surgeons to me. But if I don't teach them, who will? And so the conflict revolves around a lack of operating room time. And so Canada is extremely inefficient with its healthcare resources, especially being in the operating room. And so we're constantly under the gun to get our cases finished on time. The nature of vascular surgery, though, is that it is highly unpredictable, especially with larger cases, as to how the case will go. No matter how much preparation we do, the cases are still unpredictable. And so with that in mind, I typically, in the first half of my career, I would take the case away from the resident. I would do the case. For one thing, I was more concerned about finishing the case on time, and secondly, I was concerned that I could do a better job than the resident could. And so this was brought to my attention one time, and I couldn't believe it, but a patient actually said this, because we operate on this patient's carotid artery on both sides of his neck at different time points. And afterwards, the patient said, both in front of me and the resident, he said, the surgeon did my right side and the resident did my left side, and I can tell. And I couldn't believe it because the patient was under general anesthesia at the time, and that it was absolutely correct, and that I did the right side and I supervised the resident to do the left side. And even though the external appearance appears identical, the patient could actually perceive that difference. And then I realized that, in fact, what you do in the operating room, how careful you are, makes so much difference to the patient. I would say in the second half of my career, it suddenly dawned on me, probably was gnawing away at me, that I'm not getting any younger. And at some point, I'm going to have to retire, and one of these young doctors will probably end up operating on me, or one of my friends or relatives. And so I really better do a much better job in teaching them how to do this operation. And so the second half of my career was focused on developing the careers of the other young doctors in particular. I would spend, in some ways, an excessive amount of time fussing over the specific details of every tiny little procedure, every stitch, how to get it perfect, and giving a rationale as to why it should be perfect, why it should be done in this way. And so in my own way, I was very obsessive compulsive in the operating room, because we are responsible to the patients. And I would say at this time, I became far more aware of a patient's preference in terms of do they want an operation or not. And this coincided with what was coming out in the literature, in that the natural history of certain illnesses is not as necessarily gloomy and as the literature would say. And so I'll give you an example. One of the things that we treat are aortic aneurysms, and aortic aneurysms can be fatal if they rupture, and if they're large and they rupture. And so we generally go with a size criteria. If the aneurysm is of a certain size, then we recommend operating. But there has been more data that's come out suggesting that the natural history of untreated aneurysms, especially in older people, is not as gloomy as the original literature would say. And in fact, you are now talking about competing reasons as to why a patient would die. And most likely, elderly patients with large aneurysms don't die from their ruptured aneurysms. And so with that knowledge in mind, I would counsel patients in a way to try and get their preference as to how they would like their treatment to proceed. One of the things that was disappointing to me, in that as a career researcher as well as surgeon, the area that I was particularly interested in was a special type of scarring that occurs whenever one operates on a blood vessel. It's kind of like, you could say, adhesions or large scars on the skin. And this type of response is really a standard inflammatory response. It's a bodily response. The disappointment I had was that in 1997, a group of investigators at the Cleveland Clinic, and I had been going there every year to that annual meeting, basically declared that the research into this area known as intimal hyperplasia was over, because there was more and more compounds that they had uncovered. Every time they tried to identify a compound, treat the compound, a new one would appear. And so the body has built-in mechanisms, probably adapted through evolutionary processes over millions of years and conserved through different species, that you cannot inhibit inflammation, especially with just one or two chemical molecules. And when they announced that they were going to stop further research in this area, there was now a void in the management of these patients if you're not going to be using special drugs or chemicals against it. And what filled the void was in fact devices. And so the devices enter the world of vascular surgery. And in fact, vascular surgery, if you think about it, is nothing more than fancy plumbing. You have a pipe and you have fluid that runs in a pipe, and something goes wrong with the pipe. The pipe either gets clogged up or it gets weak and balloons out. And so in its place, because there's no advanced research in this area, all the device companies were now making devices to treat what they thought was essentially were pipes. And in fact, that's one of the disappointing things, in that they're treating a biologic organ which can respond, and no matter how different the device manufacturers came up with the different devices, you would still have the same problem of intimal hyperplasia. Nonetheless, this swept the approach to vascular surgery, as well as, I would say, cardiac surgery, because cardiac surgery is very similar, that it is, again, smaller blood vessels. With that, I came across a number of very interesting articles, and one of the key articles I read was actually published in the New England Journal of Medicine in 2009, and this was an article about a class action lawsuit that citizens had brought forward against a drug manufacturer for this drug otherwise known as Neurontin. And Neurontin, for those who don't know, is a drug that is available only to treat childhood seizures. And the Neurontin story is that at the time it was developed by a smaller drug company, and the CEO was unhappy with the fact that there weren't a lot of sales because there weren't a lot of kids with seizures. And he made an announcement to his entire staff saying, I want Neurontin to be the drug of choice for everything. In other words, everything from a headache, from a toothache, from any pain in your body. And it was his campaign on how they would market Neurontin, which was most striking in this article. And how they did it was they captured the entire medical industry. They did it by buying off highly seasoned medical educators, by paying for dinners, by paying for junkets to fly physicians to various parts of the world to enjoy a brief holiday and be educated on the wide uses of Neurontin. They also did it by paying off hospitals, universities. They did it by writing fabricated articles and having the names of these doctors on these articles. And I presented this article at one of our rounds shortly after in 2009, since I found it such a fascinating thing. And the reason is because during our surgery, we frequently, because we operate so quickly, we frequently damage a peripheral nerve. And a peripheral nerve, most commonly damaged in our operations, is a nerve that runs on the inside of your leg, and it's only responsible for feeling, for sensation. It won't affect any motor function. But this nerve, most commonly, when it's injured, it will respond by indicating the pain in that area. And so the pain is described in medical terms as dysesthesia, or burning type of sensation, which will last maybe several years or longer. So the irony of all this is that we're frequently operating on patients who have pain when they walk, and we can eliminate that pain with our procedure, but instead we have now given them a new type of pain on the inside of the leg, which doesn't happen just with walking. It's now constant. You're having it all the time. And so reflexively, because Neurontin had so much penetration at the time, it is now routinely taught in medical school, down to residency, down to all the staff surgeons who then teach it back to the students that if you injure the nerve and this is the patient's symptoms, you simply put them on Neurontin. The reality is that Neurontin has never been demonstrated to have any effect whatsoever in that area. I gave them a typical presentation of a patient who had been injured in this way. They're now experiencing this type of symptom. What would you do? And every one of them said Neurontin, which led me to the presentation of this class action lawsuit. This drug was subsequently, I believe, bought by Pfizer, and the class action lawsuit was against Pfizer. After that, I went on the ward to see how many of my residents and students who had heard my talk actually stopped using Neurontin. And to my dismay, I found that virtually all of them continued using Neurontin, even though they attended my talk at the time. I gave the identical talk 5 years later to the exact same group of surgeons, because the surgeons never changed, but with a new group of students and residents. And the exact same thing happened again. In other words, with this scenario, the first recommendation that they would say is that give the patient Neurontin. I would then ask the surgeons and they would say the same thing, and then realize that nobody really understands anything here, And so, number one, you're not reading the published literature. Number two, if somebody's actually talking to you about the published literature, you're not listening. And so you have no inquisitiveness as to any of this. You're just, it's like one of my former teachers said, in surgery, you only use the back half of your brain. You don't use the front half of your brain. So the front half of the brain is higher functioning, it's for thinking. The back half of the brain is reflex. And so what he's saying is that as a group, surgeons don't think. You only react to a situation. And he's right. What happened, I would say, after that was that with my disappointment, a few unusual things happened in the world. And I would say in 2019, I came across an article in CBC talking about the Winnipeg Level 4 lab, and somehow the 2 Chinese investigators were let go. And I thought that this was a very unusual piece of reporting because there was no explanation as to why they were let go. And then I suspected that in fact they were spies, and that all their graduate students were also spies. And as a result of that, I started to look into what's the possibility that they truly are spies. There was another separate article, both preceding it and following it. And the preceding article was that there was a shipment of lab material from Winnipeg to Wuhan, China, that was carried on an Air Canada flight at least 1 or 2 months earlier. And it was suspected that there were viruses, because that's what they were studying, that were sent from Canada to Wuhan. And subsequently, the later report was a denial by CBC, Canadian Broadcast Corporation, that this is not any conspiracy theory. For those people out there think of these as spies, you should just cut it out. And I was thinking, now why would they say a thing like that unless they're really trying to cover it up? And so I was highly skeptical about that. And in 2019, the latter half of I would say the very end of the year, very unusual things. There was a report about a new SARS-like virus that again had come out of southern China, and they thought that they could contain it. But I came across a small report, and it was reported by the Taiwanese government that there was person-to-person transfer of this, which was then vehemently denied by the communist regime in China at the time, which I thought was typical of them, and in all likelihood, there must be person-to-person transmission. The following month, which was the following year, in January 2020, when this virus appeared not to be contained, and you read reports that the countries immediately surrounding China, which had experienced SARS-1, this would be South Korea, Japan, Taiwan, Singapore, they basically closed their airspace to incoming Chinese flights. And I thought, well, okay, so this thing really is going to spread quite quickly. And the U.S. government later in the month also closed their airspace to incoming Chinese flights. And I thought that the U.S. government must know something. But the Canadian government, I was waiting for a response from the Canadian government, because we usually follow what the Americans do. They came up with a very unusual statement saying that this was a racist thing. And so that they were not going to do this, they were going to continue to allow Chinese flights to come in, which I thought was a very foolish thing. Then I would say the whole COVID thing just exploded in February, March, when our hospital had to respond to this, and so we had to empty out half of the hospital beds. We had created all these backup measures. The waterfront hotels were considered to be backup stations in case there was overflow of patients. And we just waited and waited. Nobody knew what to think or say. And then all this very unusual activity seemed to start. Initially, there were reports, Fauci was saying what we all knew medically, that masks don't work. And even in the operating room, we know that masks don't work. It's only to prevent any direct fluid contamination from the operating room staff to, let's say, an open wound. But then 2 weeks later, he flip-flopped and said that everyone had to mask up, and it didn't make any sense. Why would you say a thing like that? What is the evidence? Do you actually have evidence of the last 2 weeks? And so there was no evidence, and this was highly unusual. And the other really unusual aspect of this was that the key medical journals, meaning on this side of the Atlantic, it's the New England Journal of Medicine. On the other side of the Atlantic, it's the Lancet. The New England Journal of Medicine said that information regarding this new SARS-CoV-2 virus is so new, and we don't know anything about it. We are going to dispense with peer review. And I couldn't believe it, because this is the most heavily peer-reviewed journal in the world. And they were going to dispense with it, and they were just going to publish whatever came in. And soon after that, there were reports, this was over hydroxychloroquine, when there was some limited experience reported by the French doctors that they had used hydroxychloroquine in their hospitals with good results, to which the American doctors largely poo-pooed it. And I thought that this was hubris from the American doctors, thinking that they should be first with a discovery like this. They didn't think that any Europeans really could, produce anything, any worthwhile research data, and very typical of North Americans. But then the New England Journal of Medicine put out a publication that was against hydroxychloroquine, which was soon retracted, I would say within 2 weeks, by a group that I'd never heard of previously, which came out and demonstrated that the original hydroxychloroquine article published in the New England Journal of Medicine was in fact fabricated. And so that was a shock, because here I lived all of my professional life believing in literature, especially in peer-reviewed literature, and then having this very quick retraction. And so all of this didn't add up. Then you add into what was actually happening in 2020. There was a massive US election at the time, and there were a lot of forces trying to destabilize that election. We had Black Lives Matter riots throughout throughout America, and to some extent they also came here. And a small way, both in BC and Alberta. But for Trump to actually come out and say that he's going to initiate this Operation Warp Speed to develop a new vaccine, whereas I didn't understand how you could develop a new vaccine when it was acknowledged that it takes at least 10 years, possibly 15 years to get a new vaccine, to get long-term data from it. And how could you accelerate that? In other words, how could you contract the time required to see what the long-term effects would be within months? And then it became highly political that the vaccine manufacturers said that they had a candidate vaccine and they were about to release it, but they wouldn't release it until after the US election in 2020, which was highly circumspect that this is all very political. On top of that, the CEO of Pfizer dumped a majority of his stock in August 2020, which was a red flag to me that clearly the CEO knows that this stuff is it's going to have a momentary effect and it's going to crash and burn. And even when I asked my financial advisor at the time, they basically disclaimed it, saying that the CEOs, they routinely do this, they got to sell a bunch of their stock at a certain time point, but I just didn't believe that. And so I would say that just waiting for all these COVID cases, I came across Bhakti's small monograph, something like Corona non-virus or something like that. And it was very, very interesting. And he's talking about PCR. And so during my training, I had done a summer of molecular biology, and I was fascinated by the fact that you are measuring micro to nanograms of very small materials, but at the very end, you just run it through this gel electrophoresis and you just look at the bands. And I couldn't understand why you were so particular in one part of the procedure, but so sloppy at the end, where you just are looking at the intensity of these bands. And I knew that it probably is fairly easy to fabricate that. And so as a result of that, in Bhakti's book, when he talked about the use of the PCR test, it was very telling. He said that this was invented by a German scientist who managed to produce a PCR diagnostic test within record time, and in fact it got published within a day. And then Bhakti basically talked about all the inaccuracies associated with this. I knew from my time in molecular biology about Kerry Mullis because he shared his Nobel Prize with UBC's one and only Nobel Prize recipient. Kerry Mullis was a brilliant person, and he himself came out and said that this should not be used for diagnostic purposes for the individual patient. And so armed with that, I questioned what exactly is it that a case constitutes. And so when they started talking about cases based on PCR tests and knowing the problems associated with high number of cycles in the PCR method, I was quite skeptical about the total number of COVID cases. And so when 2021 rolled around and the mRNA vaccines were available, it was an unusual time because prior to that, I knew that mRNA had been, or this type of genetic type of therapeutics had been around for a long time, but not used very successfully at all. They've had consistent failures. And when the original publication regarding the Pfizer mRNA vaccine came out in the New England Journal of Medicine, it was actually a very disappointing article in that they had a large number of patients, but they used a term in the paper called vaccine efficacy, which was a new term that most physicians were not aware of. However, vaccine efficacy is the same as another term that most physicians are aware of, and that is relative risk reduction. And so when they claimed a relative risk reduction of 92% or so, that is a measurement of groups, not of individuals. And so that type of measurement should only be used to compare groups. In other words, one type of vaccine to another type of vaccine. On an individual level, which we as physicians, we treat patients individually, we should never use relative risk reduction unless you want a patient to take something. In other words, the relative risk reduction, that number is usually very, very high, but the true advantage for a patient for a new drug, for instance, is a measurement called absolute risk reduction. And the absolute risk reduction in the Pfizer paper from the New England Journal of Medicine in December 2020, even though it was not specified, if you had any training in clinical epidemiology, and by the way, every student and every resident has had training in clinical epidemiology for the last 30 years. And so if you remembered anything from your clinical epidemiology as a physician, you would have been able to calculate the absolute risk reduction, which in fact was 0.7%. That is to say, with the patient directly in front of you, if the patient asks the question, what happens if I take this vaccine? The true answer is, by taking the vaccine, it will decrease your risk of COVID, not severe COVID, not death, but COVID, in other words, getting a cold, by 0.7%. That's it. And I have never heard ordinary physicians talking about this. When I explain this to ordinary physicians that the advantage is only 1%, they then go on to exclaim, well, 1% of the overall population is actually pretty good. Not realizing that we're not talking about death. We're talking about a case, reducing a case by only 1% by taking this. And so if you understand that, and also understand that the entire paper is only based on 2 months worth of data. There is no long-term data beyond 2 months in that paper. You soon realize that the whole thing is a house of cards. You have a rushed vaccine using a technology that's never been proven. It's so rushed that the preclinical, the animal studies, the animals either died or they didn't do it. Your absolute results are dismal. You have no long-term results. For what? And so how bad is COVID really when you don't have an accurate diagnostic test and you can't figure out who has COVID and who doesn't? And so with that in mind, and the government sort of ratcheting down on, first of all, people in long-term care, then they came after the healthcare workers. I delayed and delayed my decision until the choice was either to continue, you're going to have to take this, or we're going to fire you. And so I thought, well, I don't want either, and so I'm not quite ready to retire, but if that's a choice, I choose to retire. And so that, effectively, that's what I said. But before I said that, I did send an email to all of the senior administrators of the hospital saying that, whatever you do, don't impose this on your medical staff. Because I think that what is really missing in this is leadership. And are you the ones to really lead us through this? And so none of them responded to that. And I think that one of the key problems we have now is that there is no leadership. So from that, it's a little bit disappointing as to what had happened. I would say that there were very, very few physicians who actually, took a stand. Unlike the situation in Quebec, where I understand that 20,000 healthcare workers essentially went on strike against the forced mandate. And Quebec is the only province in Canada as a result that doesn't have that. They backed down as a result. And so if we had a significant number of healthcare workers who at the time stood up and said, this is ridiculous, we're not going to take this, this whole thing would have been over. But it is what it is. And so I would say that the small group of doctors who didn't take this, somehow we've found each other, initially on Telegram, and then it went over onto Signal. There was an early attempt to form a physician group, but that physician group, I think, was very conservative. They didn't really want to speak out. It was really just a chat session where people could get together and just vent. And so for me, it wasn't particularly satisfactory. And in fact, Steve Pellick was one of the guest speakers at the time. And Steve was describing this organization called the CCCA, which I was quite intrigued about. I looked it up, and Steve suggested that, well, in fact, I think it was Steve who suggested that, there are a bunch of different chapters of the CCCA or otherwise committees. Why not have a BC chapter? I proposed this within our small group. And so initially I was tasked to go find out about it, which I did. And when I suggested it to David Ross, he said, that's a great idea, why don't you chair it? Then I came back with that idea, and I would say our group leader at the time didn't like the idea, thought it was fracturing our group. I couldn't understand why. And so I would say maybe about 3/4 of the doctors were kicked out of that group, including myself. And so as a result of that, those docs who were kicked out, we've formed our own group, tried to structure ourselves as to what we wanted to do, and it became apparent that some were interested in legal action, some were already involved in some type of disciplinary action against themselves anyway, and they had retained a lawyer to do this. And so that's when we decided to incorporate a society. That's the Canadian Society for Science and Ethics in Medicine. And once incorporated, you needed officers, and at that time, I don't think I was that vocal. I was supportive of it, but it appeared to me that the majority of the doctors in that group wanted to be part of that group, but wanted to be in the shadows. And it was quite apparent that if we're all in the shadows, nothing will ever get done. And so I would say that probably one of my strengths has been throughout my career is to develop something from nothing. And so that's what I did. And so they needed a leader for this, and they asked me if I would be the president, and I agreed. So I was the first president of the new society of the CSSEM. And then as a result of that, I felt it was my responsibility to lead this group, and you should lead by example. And so that's why I have put myself out in the public, doing various interviews and educating the public about my story, but in addition to that, the story of others, of how medicine used to be, the importance of consent, and what we have been given, there has been no consent whatsoever. So that has been very disappointing, since the majority of the doctors who accepted the vaccine and gave the vaccine to patients without providing informed consent is appalling. And quite honestly, they should all be ashamed of themselves. How can you really call yourself a physician when you don't know something? You have the capability of finding out about it, but you choose not to. And so, in a way, if you look at my experiences with trying to educate physicians about alternatives, about proven alternatives, they are still unwilling to look at it that way. And it's much easier for them to continue doing or repeating the same mistakes as they have done for decades. And so that's overall very disappointing. What do you think about that? Yeah? I'm sure there must be some questions you want to ask.
I certainly have one for the last thing you were mentioning about surgeons not being willing to listen. First about Neurontin and the abundant proof that it wasn't actually an appropriate medicine for the things it was being marketed for, and also about surgeons and residents all having clinical epidemiology, and so being perfectly able to calculate absolute risk reduction numbers, and yet not getting a clear, realistic, sober idea of the risks and benefits of the mRNA vaccine in spite of their training. What do you think is really at the bottom of this? Is this peculiar to Canada? It seems like we've seen it all over the world, but are doctors today limited by their privilege? Is it an institutional culture? Is it a side effect of over-specialization? What do you think?
Wow, that's a great question. What I think is that medicine is a club, and it's a closed club. And by that, what I mean is that when you gain entry into this club, you have to follow the rules of the club. Whatever you did before, put it aside, because these are the club rules. And by that, what I mean is that there are so many club rules that we can't teach all of it in 4 years. And so medical knowledge has expanded dramatically, but medical school education has not increased at all, not even by one day. And so how do you cram all this information into a medical student? And so what you have is you have competing specialties fighting for a little bit of a medical student's time to tell them one of two things. What's the best thing? What the things that they absolutely need to know? And typically the things that you absolutely need to know are the things that will kill you first. And so, but those things that will kill you first are the least frequent. And so what we teach medical students is we teach them the least frequent but most deadly things. And we don't teach them any of the very common things, and so they have no common sense whatsoever. The other aspect of it is that we try and impress upon medical students why they should come and be like me, and join my specialty. And so there's a bit of salesmanship that goes on. But more than that, the way that medical students are taught is completely illogical. And by that, what I mean is that we teach them diseases. We don't teach them health. We're not in the business of health. We're in the business of disease. We're in the business of diagnosing diseases and treating them either with drugs or surgery. And that's medicine. And by that, what I mean is that a medical student, when they finish their medical training, it is not the end at all. It is a road bump on the way to specialty training. But at the end of your 4 years, you have to be able to take a history and do an examination within 20 minutes. Because there are so many patients to see, you cannot spend any more time doing that. And as a result, what we're going to do is that we're going to pigeonhole your thinking. If you are able to think clearly on your own, reflectively, we're going to eliminate all of that. You are going to react. You are going to react to a patient's symptoms. Certain symptoms will make you think of certain diseases, and certain signs, meaning what you find from physical examination, from your blood tests, x-rays, will point to certain diseases as well. So we are going to heavily regiment your thinking to pigeonhole it, and you're going to do it in a structured way without any deviation from it. And that is medical school indoctrination. If you had the ability to think on your own, we're going to completely eliminate that. And I think that that is the indoctrination of every medical school that teaches allopathic medicine around the world, which is really, as COVID has shown, is tragic, because the vast majority of physicians are unable to think clearly. In other words, you have no common sense. You're not following your gut. You're doing what you're told to do. You're practicing medicine based on guidelines.
And is this related to sort of the removal of responsibilities over the past decades from generalists and family doctors? It seems like we've got a great dwindling of family doctors, and maybe we've removed them from the hospital setting. Do you think that this is the wrong direction to go? Is there something about encouraging the generalist and the family doctor that might be helpful within this system?
No. The choice of what type of doctor you're going to be is made to some degree by the student themselves, and to a large degree by the funding that comes with it. And by that, what I mean is that the funding for the post-educational training of physicians is provided by the provinces. And so in the province of British Columbia, by and large, half of the medical school, half of the students would choose a specialty outside of family practice, and the other half will choose family practice, not necessarily of their first choice, because it is all based on funding. We have an unusual system in probably every medical school in North America right now, where we don't have grades, we don't have marks. We have no idea how good you are. There's no objective way of knowing that. Yet at the same time, you have to choose a residency. And so you have to write letters, you have to get letters of reference, and every time the problem is let's say I'm selecting a medical student to come into my specialty of vascular surgery. How do I know this student's any good? I don't know their grades. I don't know there are no marks. All I know is how many elective rotations did you do to demonstrate your keenness in my specialty, and you got a few letters of reference. And so if you did not do almost all of your electives in my specialty, it means that you're not interested in it. And if you have a lukewarm letter of reference, it's a red flag. And so that's all we have to choose from. Now, from the medical student's perspective, in order to, because they're not entirely sure that they're going to be matched to the specialty that they want, they're going to have to back it up with a second specialty, second choice, in case they don't get their first choice. So oftentimes, if a student wants to do, let's say, my specialty, vascular surgery, but they realize that there are only one spot per university in Canada. So across Canada, we take 10 medical students nationally across the country. And so it is highly competitive. And so usually, on an average, there's about 25 to 30 medical students across the country that apply to my specialty. They know it's so difficult to get into. Most do not choose this specialty. And as a result of that, those who do choose a specialty will back it up with something else. And something else may include something like family practice. And so I would say that those doctors who end up in family practice residency, the majority have chosen that, but not all of them. And probably about 20% have used it as a backup. The division is not really in family practice and internal medicine, since both are considered specialties on their own. There are certain specialties that are, in fact, easier to get into in Canada than other ones, and all the surgical specialties are extremely difficult to get into. But what I said in terms of the indoctrination of medical students, and so when you come out, that's exactly how you will perform, how you will think. That's the product that we have created.
Can you think of any particular measure that could be taken to improve the education of medical students? Is it a question of adding more years to the program? Is it a question of insisting that all students take electives in a wider range so that they do have a general understanding of the field, or that they reinstate grades?
I think because we don't know our history, we are forever doomed by it. By that, what I mean is that there are some things that we used to do that clearly are better than how we do them now. And so some of the examples would be when we had grades, both letter grades and numerical grades, at least it was objective, it meant something. But I think more than that, it depends on the type of doctor a society has. And so you're in a bit of a conflict between how much time to train the doctor as well as the expense associated with it. One of the problems we have is that medical school education is highly, highly subsidized by the government. And so I don't know by how much, but I'll give an example. I suspect that medical school in BC is probably about the cheapest across the country. It's about $20,000 per year. But I think to actually train a medical student is probably in the order of maybe about $60,000 to $80,000. And so you can see that the public has some investment in the training of that medical student to become a doctor. And because of that, don't you think the public should be given a say when 20% of the public has no family doctor, yet they have contributed to the education of all these doctors? They're getting nothing for their money. I think that a number of things could be done to really improve things. I think number one, I think the selection of medical students should be completely different. As an example, I'll give you my personal example is that when I went to medical school in New Zealand, we had no interviews. It was entirely based on our marks. And so there was no interviewing process that goes on. Here, throughout North America, there is an interview process. You have to have a certain qualification in terms of your academic performance and marks, but if they think of you favorably, then they'll invite you for an interview. You can clearly game the interview. By gaming the interview, there are courses you can take. You know what type of questions they're going to ask. The interviewer has some idea of the type of, let's say, medical student what type of student they want to enter into medical school. And I think that their choice of that student is entirely wrong. And by that, what I mean is that when you decide to take on a student to go into medical school, they are all overachievers. And so since they do not want just book smart people as how it was previously, and the rationale for having just book smart people, let's say my university in New Zealand, was that their philosophy is that medicine is so broad, it doesn't matter what type of personality you have, we will find something for you. There are specialties in medicine where you see patients. There are specialties you see no patients, and so does it really matter that you can communicate well or not to a patient? Probably not in a specialty where you don't see any patients. But here in North America, they place so much emphasis on that extra bit, and by that extra bit, I mean that they want someone who is overall a great person, that they have done something amazing, that they are an incredible athlete or incredible musician, or they have traveled the world, or they have volunteered for this or that. And so it's nothing but gamesmanship. The problem is that when you choose a student to become a medical student like that, when they finally finish, guess what? They don't want to be a full-time doctor. They want to go back to be that amazing person. They want to be that amazing athlete, musician, travel the world, do all those things. And medicine is something you do as a sideline. You do it part-time. And I think that is one of the huge problems that they have, because somehow the public has been trained to think that the best doctors are the ones with tremendous overall appeal. And so they're trying to seek out those type of people with tremendous overall appeal. Whereas in fact, the number of hours that I have worked as a physician on a weekly basis of my entire generation, we need 2 medical students to replace every one of us. That's reality. I mean, we worked at a time where there was no restriction in how many hours you could work, and because it was your calling to practice medicine. That's what you did. You just did what needed to be done. And I think that, number one, they have attracted the wrong type of student to go into medicine. You want dedicated students who regard this as their calling, number one. Number two, the distribution of physicians in Canada, BC in particular, but BC is really no real exception, is entirely disproportionate, and there has been no attempt whatsoever made to try and balance it out. By that, what I mean is that the majority of these well-rounded people want to live in the larger metropolitan areas, because that's where you can do your arts. You can be not too far from your sporting activities. You can do all your traveling because you're close to a major airport, this type of thing. And so again, you have attracted the wrong people to go into that. What I personally think would be better is for the people of British Columbia to have more say in the selection of their doctors. And by that, what I mean is that I think they should remove the subsidies at the university level in medical school, because I don't know where all that money goes. The public funding of medical students, it doesn't go to the educators themselves. It goes to the administration of the medical school, who don't really do any of the educating. The one-on-one, the one-to-the-group type of education. And so I think that all those subsidies should come off, and students who want to go have to pay the full amount. On the other hand, I think that smaller communities should set up a bursary system similar to the system in the armed forces, where you would have a bursary or a scholarship for a student, not necessarily from that area, that you would sponsor either full or partial ride, but the payback is year for year. In other words, once you have qualified, you need to work in that community that basically sponsored you to go through medical school and pay back on a year-for-year basis. Because one of the things that was exceptional before we got into this medical mess was we had a year known as rotating internship. And that was a year after you graduated from medical school and before you went into residency. Rotating internship was the best year of any doctor's life. And by that is that you would do various rotations, but afterwards you would do your medical licensing exam. And if you wanted to, you could go and practice as a family doctor. And if you wanted to go on to do a specialty, you had now seen what other specialties had to offer, and you could then do a specialty. The problem now is that in medical school, medical students need to make up their minds as to what they want to do by the beginning of their 3rd year. This is after 2 years into medical school, because you have to apply by the end of your 3rd year. So this 4-year idea then going on to choosing a specialty is, in fact, you need to figure it out in 2 years. And in 2 years, as a student without exposure to anything, how could you actually choose the right specialty for yourself? And so I think that there are a number of examples where we could, in fact, improve the distribution of doctors throughout the province. We could decrease the costs of medical school. We could get rid of a lot of the, I think, excessive costs in medical administration, since I don't think it doesn't do anything to the education of the physicians. And what you're doing is you basically are running interference with what really goes on at the educational level between the clinician and the student.
I would like to ask you a sort of a broad question of your opinion of the future of access to medical treatment in British Columbia in view of the mandates that were brought in to force non-consensual vaccination with what many people still see as an experimental products, and in view of the BC Health and Health Professionals and Occupations Act. So I'm wondering what your opinion is of the future for the right of access and the right to deliver for medical professionals healthcare that is timely, competent, and delivered with the appropriate consent of the patient.
Wow, that's a big question. All right. I think we're in big trouble. I think we're in big trouble right now because, not just because of the forced mandates that have affected a significant number of healthcare workers who do not appear to be getting their job back. But in addition to that, the perfect storm is that this has happened at a time when the baby boomers are all retiring, and the baby boomer healthcare workers are all retiring, and there are not enough to replace them. And they are retiring because of age, because of this forced mandate that they don't want, and because of electronic health records, which requires a significant knowledge of computers. And so by that, what I mean is that it has gotten rid of paper charts in hospitals. And so there's no charting going on. There's no one's writing anything. So if you can't type, you're out of luck. So you either have to type or do voice transcription. And I would say that a lot of healthcare workers, my age, maybe younger, see this and say, I'm not going to do this. I'm out of here. Now you add to that problem by sudden withdrawal of a significant number of healthcare workers, and the remaining ones have to pick up that slack. The remaining ones have been vaccinated. They're getting sick with COVID. They have to do more work, but they're getting more sick. Absenteeism has doubled as a result of this. When they get overworked, at some point they're going to say, I quit. And so that problem is going to be compounded. Is there relief on the way to replace them? I think not. I think that every jurisdiction lacks for healthcare workers. And the idea that you could simply import a whole bunch of healthcare workers from other areas simply is not true. If this is true, then show us the proof. Why do we have daily reports of hospitals? They're either the healthcare workers are unhappy because they're overworked, or patients are unhappy because they're not being seen. There are now mistakes, complications as a result of excessive waiting. I don't see any benefit coming from that. Now, on top of it, you want to introduce the Health Professions and Occupations Act at a time when the healthcare workers are so stressed. Why would you do a thing like that? How could it possibly benefit healthcare workers when you portray them as being some type of evil, and the government needs to do this in order to protect, maintain the safety of patients, calling their healthcare workers as potential evildoers. And so the introduction of this is beyond belief, quite apart from what it actually says. I think that we're in for a lot more pain, and I think that it probably will not be a slow, gradual drip process. I think it will happen quite quickly. I think that we're very, very close to when the wire is going to snap, because I just talking to health professionals around the province, it seems that elsewhere, outside of the metropolitan areas, they are severely understaffed. They're now having to move patients to other hospitals. They're having to fly patients down to Vancouver for fairly trivial care. In other words, sometimes just for an x-ray. And I think that it is just an impossibility. I think that the government they have no idea how to manage this crisis of their doing, of not only their doing, but governments before them. And yet, they are the government of the day. And so, when you have fewer and fewer, let's say, physicians in particular, and you don't have enough family doctors because those in family practice have chosen not to do family practice. They are working in walk-in clinics or they are hospitalists, and then you decide to give the family doctors in family practice a 30% increase. What do you think will happen? And so one of the unintended consequences is that all those family doctors working in hospitals as hospitalists or working in clinics now want to become family doctors. And so that's a problem in hospitals such as Surrey as well as elsewhere, that there are no hospitalists. They all want to go back to do family practice. They're all chasing the money in this case. I don't know where you're getting your money from. Can you print any more of this? Can you entice hospitalists to go back to work with more money? If they do, what will happen to family practice? You haven't addressed the fundamental problem, is that the patient is the one who suffers. The patient either suffers by not being able to access any family physician, or the patient suffers by going into hospital and having to wait and wait and wait because there are no physicians such as hospitalists who are able to look after them. I think it's just a lose-lose for the patient. I think that this is close to the snapping point, and something fairly radical will have to be done.
I also wanted to ask you, from your 3 years of experience as a advocate for ethical and informed and competent medical treatment, and your stewardship of the Canadian Society for Science and Ethics in Medicine, have you seen an opening up of amongst medical professionals of the questioning of the scientific and medical justification for what has been done to all of the patients in British Columbia through the COVID measures? Have you seen more medical professionals willing to do anything close to what you yourself have done? And that is to step up and step out and speak out and continue doing that and trying to make a positive difference?
Sadly, no. I think that the physician colleagues I knew before have not changed their minds. I think what's happened is that this behavior that they have chosen, most likely they weren't even aware of choosing it, as if there was a choice. It has now been normalized for them. And so I think that they are just going to continue going down this path. Some of them I've spoken to, because every so often I'll hear comments like, wow, we're seeing a whole bunch of cancer cases, and I try and open up that discussion a little bit more, like, why do you think that is? Do you think, and if I say something like, more direct, like, do you think it's related to the vaccine, or possibly could be related to the vaccine? There's a hesitation and said, we can't talk about that. And then I know that their behavior is completely normalized, and that someone has told them you can't talk about this, so they don't even think about it, which I think is very, very sad. I think that there are a few unfortunate physicians who probably have been vaccine injured, and I think that they clearly regret their choice in taking a vaccine. Regarding the CSSEM, we're pursuing our judicial review, and we look forward to the hearing later this year. At the same time, I think that my experience talking with my colleagues regarding the mandates hasn't changed, although newer things like Bill 36, some physicians are more willing to talk about that issue. The society as a whole is also starting to branch out to look at, if you like, life beyond COVID and the mandates. And so some of the areas that they're branching out into, they're looking at some of these things we hear about. A big financial crash, that there's a small investor group. If there's a crash, how would you best prepare for that? We have a prepper group as well. Others, and one of the things that I'm interested in is looking at a possible parallel health system because quite honestly, I'm not the only one who's dissatisfied with the health system that we're in. I think that COVID has opened up our eyes to the fact that there are many different ways of looking after one's health. And I think that going forward, since we're not entirely sure what healthcare is going to look like, maybe we should be at that tip of the spear, if you like, to try and find out what possibilities or avenues are there to create a different healthcare system.
So part of what you're saying is that the healthcare system actually is switching into a health robbing system, if you like, because of a number of factors that have all been worsened by or demonstrated in a way by the COVID responses and now by the BC Health Professions and Occupations Act. What are your thoughts about what medical professionals can now do and or non-medical other people can do to ensure access to competent individualized healthcare in the future? And when you're answering that question, please answer it as broadly as possible. So referring to a parallel system, referring to taking court actions, whatever. What is your opinion of what can and must be done to preserve universal health care? That's a very big order, not just preserve health care for a few people, but for everybody.
That's a really challenging question because, number one, there's no quick remedy to the fact that 20% of the population has no family doctor, and so their access will always be poor. Then the only way that they'll be able to access healthcare is to go to the emergency room, and that is not going to change. In fact, if anything, it will probably worsen. Even this idea of the second medical school out on Simon Fraser University, number one, it's going to be too slow to really make a difference. And number two, they have no ability to control where their graduates go. And so it could be that, in fact, their graduates don't go into family practice either, probably because they have used the exact same selection criteria for the people that go into their university. And so, but that experiment, we won't see results until at least 7 years from now. So in the immediate future, healthcare is going to remain as fractured as it is now. I think that the development of a parallel health system is at its beginning stage, unknown at this point how much impact it will make. But I would have thought that if 20% of the population can't get access to a family physician, or in particular to a family physician open-minded, to treat independently, not based on a guideline, to actually consider the desires of the patient and put that first, I think that this will probably lead to a steady movement of patients towards a parallel health system if there was one available and could provide this type of care.
And lastly, this is really related to what you're just saying and also to the very name of the organization that you started, the Canadian Society for Science and Ethics in Medicine. What do you see as being what could be done in order to enable the maximum number of medical professionals and patients to resist the mandated non-consensual medical treatment, which is it came through COVID, but it's definitely there in the BC Health Professions and Occupations Act, where they won't have to resort to having the public health officer make mandates. It'll just be up to either appointees. There'll be appointees, people who don't have any independence, they don't have any competence, they don't have any accountability whatsoever. And really, they essentially will be making mandates, for instance, to mandate the vaccination of all 130,000 medical professionals and occupations in British Columbia, and then mandating that failure to then advise and prescribe those very same treatments for patients would be professional misconduct, worthy of a summary and instant suspension of license, and possibly under their criminal provisions of the Act could possibly attract enormous daily fines and or sentences of imprisonment.
There are two ways of approaching this. I think that if you're going to bring in this, obviously at some point they're going to implement this, but when you implement it, you're never sure of the unintended consequences that may happen. You may lose another, let's say, 10% of your healthcare workforce. You're barely hanging on now. Can you afford to lose another 10% and see what happens? The flip side of it is that if one health professional leaves, let's say a physician, they have maybe 2,000 to 3,000 patients. Those are 2,000 to 3,000 families that are now impacted. And I think that the population is going to rise up at some point. I'm surprised at how slow it has been to rise up, because the last time that the population said no was over this HST thing, when the population basically, but mind you, it was there was a grassroots campaign, which was highly effective. But the fact is that was effective. We used to have gas prices, if you can believe, at about $1.60 a liter. And when it hit $1.60 a liter, this is a number of years ago now, there was a mass outcry about the cost of gas, with the potential threat of stop paying your taxes. And as a result of that, the gas prices were temporarily rolled back, kind of like a nudge thing to see how far they could push the people. Well, gas prices now, it's going to go to maybe $2.20 later this summer. I haven't seen much pushback from citizens, but I think that the time is coming. And I think that no matter what the higher government, if you like, let's say the WF or the WHO, they are rolling out this thing. They're telling other governments what they should do. In some ways, they can tell them what to do, but who is going to enforce it? In Canada, we have no military. We have a massive class action lawsuit going on right now within the military itself. We don't have enough police. Many towns are very, very sparse on the ground in terms of police. We don't have the military, we don't have the police. So who is really going to implement this? I cannot see teams going from door to door, finding out if you're unvaccinated and force jabbing them. I don't think that will happen. I think that these organizations, meaning the higher bodies, WF, WHO, they can say all these things, but to put the pedal to the metal, I don't think they'll be able to do it. And so I am hopeful that either the rising up or the loss of more healthcare workers is going to signal a huge change, or the citizens themselves are just going to say enough is enough. But I think that it's important that the citizens need to be made aware of what's going on, because the government is doing its darndest to keep everything suppressed and under wraps, and trying to placate people with illusions that they're leading a good life that is unfettered, if you like, that they have all the benefits of living here, great environment, great healthcare, blah, blah, blah. But I think that it'll be up to a number of different movements to properly inform people of what is actually going on.
I've got just one more question for you.
Sure.
So we know there's thousands of nurses who have been terminated, and the provincial government here in BC seems to have no intention of hiring them back, seems very firmly set against that, in spite of all of the evidence that these severely under-tested genetic treatments were neither effective nor safe. But if there was one thing that healthcare workers within the system now, if there was one thing that they might do to encourage the BC government to hire back their fellows and to remedy some of the damage that they've done, what do you think that might be? What might nurses and physicians, what could they do?
If they were brave, they would organize themselves into a fairly cohesive group and demand that. But unfortunately, I don't think they're brave. And I think it's, as some of my Australian friends tell me, it's the tall poppy syndrome, or tall poppy phenomenon, where the tallest poppy, just chop them down because there's only one of them. And so on an individual level, I don't think that the nurses or doctors who currently are working will have any effect at all in persuading the government or otherwise. I think that this is driven entirely by ideology, and nothing is going to change that ideology except for a catastrophic event. And so I think it will be the catastrophic event that persuades the ideologues to change ways.
Well, thank you very much, York. We're very grateful that you've taken this time today, and it's been a lot. We're coming close to 2 hours, and we've learned a great deal sitting with you and really appreciated it.
Well, thank you very much.